6:9 or 20 by 30 vision last year when she came to us. Can I have a video, please? Demonstrate how to handle the vitreous loss in which the this is a small animation which will explain to you how to do this procedure. The posterior chamber on the back surface of the iris.
Oh, you broke my capsule. The vitreous is also disturbed. Where will I sit to give you good vision?
Don't worry, baby. I will place you somewhere else. Like scleral fixation.
Oh, so painful. I caused so much irritation for so long. I don't like that place.
Then, if you don't like, I will place you in angle.
That has caused so many problems in the past.
Oh, that also. Then we'll put you behind the iris.
Is it a new placement?
No, I am doing that placement for last 15 years. This
So
is now
long?
25 years. It's very easy to do it.
Show me.
First, hold with the forceps the lens, go behind the iris, clip the iris into the claw with the help of Sinski hook. Repeat the same procedures on the opposite side as you see in this video clip.
It is so easy, even I am so comfortable.
The first case is done with my friend Dr. Anand Kumta, who is a retinal surgeon. Here, the capsular IOL complex has fallen into the vitreous after 10 years of the surgery. So first we did a proper vitrectomy, removed the lens with the capsular bag in front and put an iris claw lens on the back surface of the iris. This is the first step, which is around 4 millimeter behind, 3 millimeter behind the limbus. This is an active port of 23 gauge. The infusion is inserted. Again, second active port, you can see the capsular IOL complex in the center of the pupil, and this is the passive port. A 25 gauge passive trocar. I did the core anterior vitrectomy with 3,500 cut, so that there are no adhesions of the vitreous around the IOL complex. We remove whatever we can around the lens so that we can hold the lens with the forceps. This video has been recorded with a modified system developed by us, which cost approximately $26,000, that is around $500, and you can have a 4K video recording at your place at a minimum cost. You need not buy the expensive video recording system. The lens has been brought in front. It has been supported with the other instrument. viscoelastic is used. I always avoid to use hyaluronic acid because I feel methyl cellulose is far more neutral to the body if it is left behind. Hold the lens and bring the lens and the capsular bag out of the eye from the anterior chamber. Bring down the pupil with carbachol or pilocarpine, whatever you have. Now this is the most important step which anybody can do it with. This is an iris claw lens made by an Indian company. It is a PMMA material. It has got two claws on the opposite side and a small opening in the center. Hold the lens. The claw patency has to be checked. You can see the Sinsky who is checking the patency that it is a full thickness. Always put the lens vertically. There are three sizes are available. One is 5.5 overall length with 4.25 optics for a smaller eye. Now one more step. The second one is 5.25 with 7.25, and the third one is 5.25 and 8.25. So you have a various size according to the size of the cornea. Take a two-side port opposite to each other at 180 degree opposite each other. This is a special forceps made by Epsilon. It holds the lens completely, go behind the iris, lift up the lens. You can see the marking of the lens, just dip the iris and it gets fixed. You do the same procedures on the opposite side. There is no scleral dissection, there is no episcleral dissections, there is no destruction of the limbal lymphatics. For me, it is the most vital thing in all these traumatic surgeries. Here you can see clearly the iris has been tucked onto the claw, and you can push the lens to see that it is fixed properly. Take the suture. It doesn't take more than 2 minutes to fix an iris claw lens as compared to the traumatic surgery of the scleral fixation at various stages. I have done more than 600 patients with this iris claw since '89, and we have trained more than 400 surgeons for the same procedure in my country. This has become a procedure of choice whenever we have no possibility of putting a posterior chamber IOL. Again, remove the PFC, which was introduced just to lift up the lens. This is another instrument which I always love, is the Simcoe, which with this automation, this instrument has been neglected, but it is such a wonderful thing that you can wash out the things, especially the viscoelastic, far more superior, better than the other automatic instruments. This is the wonderful, you can see the two dimples of the iris claw which is fixed, the iris which is fixed onto the iris claw lens on both the sides. Now we remove the trocar one by one. in a manner so that it does not leak. Again, whatever the PFC is there is removed. Hydrate the wound. We have always tried to find out the ways to do a high quality surgery at an affordable cost and a more simplified way that every young surgeons and even little less quality surgeon can also do that, so that they can give a good vision to the patients in a difficult situation. Plug well the vitrectomy openings, remove them carefully to avoid the leaks. The infusion is removed last. This is another case of very small pupil. This is a wonderful instrument which I always use, the Rexis marker. It is not a very important in this case, but the Rexis marker helps me to centralize my Rexis right in the center, as well as when I am trying to do a multifocal lens, because I am a fan of multifocal lens. I have done more than 10,000 multifocal lenses till today, to see that the center of the Purkinje's image, that is the first one, it right in the center of my Rexis, which is used to centralize my multifocal lenses. Now this is another thing for the young beginners. When you bend the needle, do not bend at 90 degree. Bend at about 60 degree. You can see the tip as well as the bend clearly. So when you move your needle, you are more smooth, you can visualize, and you may not miss the direction of the Rexis. I don't have to use any of these lords of the ring. If you do carefully, slowly, a small pupil surgery. Do a proper hydrodissections. Go slowly for the vitrectomy. Always remain in the center. Always remain in the center. Never cross the pupil margin. The only disadvantage in this is that the Rexis is slightly smaller because you are not using any of these lords of the ring. I am a Venturi fan, so I always use the Venturi machine, which is very fast. This is the coaxial irrigation aspiration, go behind the iris, and this is how you can do it wonderfully. This is another step which is very popular in our country. Most of the people have stopped using the viscoelastic for inserting the IOL. We mainly use the saline or whatever solution you are using to maintain the chamber as well as into the cartridge, because after doing this procedure, we always observe that the painful eye, the TAR syndrome is much less, and the reduction in the steroids post-operatively is only for 10 to 15 days, and that should be enough when you don't use the viscoelastic. There is a growing displeasure about the viscoelastic used during insertion of IOL unless there is a specific indication to use that. Remove the whatever. This is another innovation. We don't use bimanual. We use one coaxial and one bimanual so that we can reduce one incision in these cases. This is another case. Again, Simcoe. I think it's a wonderful instrument. You can go behind the lens very easily. Remove all the viscoelastic. Viscoelastic is one cause, which is, this is a very interesting case of spherophakia. The quality of this video is not a very good one because I am invited somewhere else to do this surgery. The clear lens is right behind the iris, behind the apostasis as well, the cornea. This is 2.8 main port and two side ports on the opposite side. I have tried to make the small capsular opening anteriorly. It's quite elastic to make it. This case, I don't think any of these various ECRs or various ring segments can work as good as the iris claw lens in these cases. You do hydrodissection, whatever you can. Again, my wonderful friend Simco, try to remove as much as you can. This is a coaxial irrigation aspiration. Just remove the cortical matter, leave behind the capsular bag. It will help me to push the vitreous behind when I am doing my iris claw lens. Now, if you cannot contract the pupil with pilocarpine, you can hold the pillar of the iris with McPherson forceps. Please do it gently so it does not bleed from the angle. Increase the incision to 5 mm, 5.5 approximately, because this is the iris claw lens. It comes in 3 shapes in India. It has no role to have a foldable lens in this particular design because the foldable claw will not hold the iris so well. Again, put the lens vertically. You can see the opening of the claw. It is 5.5 and 8.25 size of the lens. Put a viscoelastic. This viscoelastic is necessary. Rotate the lens horizontally. You can put this lens horizontally, you can put it vertically, you can put it in any directions. What you need is 2 tags of iris opposite to each other, and you can do it very well. Again, hold the lens, lift up the lens, and just tuck the iris. If you want to learn these things, you can take the Georgette cloth. In India it is very popular. And do it outside where you lift up the under the cloth which you can see and try to tuck the cloth into the claw. You can do the practice outside also. See, I am tapping the lens so that I am very sure that it is fixed properly. I have, out of 600 patients' eyes, we have 3 claws, 3 patients, the claw has dislodged post-operatively. One of them in which both the claws have gone and the lens has fallen into the vitreous. The 2 others where one claw has disappeared, is dislodged, the other claw was still there. And whenever that happens, don't use the same lens, always use the fresh lens. Because if the claws are not opposing each other, if you are on this way or this way, it will again dislodge again. You can see a nice dimples for see that it is properly fixed. These patients, don't expect them to have a great and wonderful vision of 2010 or 2015 or 2020 because these eyes are compromised eyes. But this procedure is the most simplified procedure I think we have today. We have one more thing which is there. You can have a very simplified keratom. The keratometry reading, you can do it. Rather, keratometry, the simplicity by which you can find out the amount of astigmatism that you have induced while taking the suture. Take a glass syringe or even the plastic syringe, remove the plug, the plunger from behind, put it onto the cornea, and you can see the shape of the piston. If it is round, you have done a perfect suturing. If it is a horizontal oval, that means the sutures are tight. If it is vertically oval, that means sutures are loose. This you need not have any extra things. It is there on your table. I use it routinely so that I have surgical induced astigmatism in these cases are minimum. This is another case of traumatic cataract which is about 15 years old with the vitreous into the AC. Take two side ports opposite each other. I am planning to have a posterior chamber lens if possible. Again, the AC maintainer, which is a very important instrument in our country. Do a proper good vitrectomy around the subluxation of the lens so that it does not come in your way when you are operating. Viscoelastic, methyl cellulose. I did a very small capsular axis because I am not sure which procedure I am going to follow, how the ECR is going to behave. So I tried to do a small axis even though it is little smaller than what I expected. I tried to put the ECR, the endocapsular ring, and you see how difficult it is, and it is not going only. The dimple of the cataract is not permitting because there is no space there. So I decided to go ahead with the phaco with ECR inside, which will help me to hold the traumatic cataract and not allowing it to go into the vitreous. This is another use I found. I tried to find out the margin of the rhexis because it was not a good rhexis. I tried to extend the rhexis, which I failed. So I proceeded with the phacoemulsification. It should be very slow, gentle. Again, a Venturi system. Again, this quality of the video is not as good as the first one because it is done at some other place. We get a lot of invitations, various places to do this surgery and learn the iris claw lens. This is extremely popular in my country. This is the other instruments, which is like a pointed, small, rod-like thing which will help you to lift up the plate of the cataract if you have not done proper chopping in a regular case also. Just try to remove whatever you can. Now a vitrectomy, and I'll remove most of the vitreous which is there into the AC as well as the capsule. All these iris claw patients which I have shown you have 6-9 or 20-30 vision post-operatively. I did about 50 keratoplasties with iris claw lens on the posterior surface. Reduce the size of the pupil with pulling the iris to the center of the pupil. extend the incision to 5 millimeter. This method has got the lowest traumatic effect onto the eye. Introduce the lens vertically because the overall size of the lens is 8.25. It has got 5-degree angulation between haptic and optic. Make it horizontal. Again, a special forceps which is made by Epsilon. Hold the lens. The trick is that hold the lens completely. Here we don't have much support from behind because of hypotony. Hold the lens from 12 o'clock to 6 o'clock as far as possible so you have a good grip on the lens. Just tuck the iris. That's all. And do the things on the opposite side. The posterior surface of the iris is the most neutral surface. So holding the lens on the posterior surface does not lead to much amount of irritation and iridocyclitis, because if you see the embryogenic development of the iris, the posterior surface comes from the neuroectoderm and not, so that is why probably it is the least irritant surface of the iris. I did a small iridectomy. Remove the viscoelastic completely with the Simcoe. You can see the claw has come in front of the iris. We did the study of some of the lenses where the quality of vision has not been so good on an OPD scan to find out how much amount of aberrations these lenses are causing on an OPD scan. OPD scan is one instrument we have. The aberrations, you can detect it from the cornea, you can detect it from the lens separately. And some of these lenses have got higher induced astigmatism. This is another procedure, I think I have 2 minutes more, where a new procedure of glaucoma has been done by Dr. Daljit Singh. This is a Fugo blade which is made by a scientist from the United States, Professor Fugo. It's an instrument which increases the temperature so high, around 50 micron. What you do in this procedure is, we already done one track. This is the second track which I am making it. Bring the conjunctiva tenon and just go into the chamber, antechamber. It forms a track of 200 micron, 1 to 1.5 millimeter adjacent to each other, and you have wonderful filtration. This is done on a topical anesthesia. I did about 250 eyes with open angle glaucoma. After success of this surgery, which is approximately 70%, now we make a small clear corneal incision. We have changed the direction now. We have gone more towards the periphery. This is a special forceps designed by Epsilon. Most of our instruments we have designed by Epsilon. We did a proper iridectomy so that none of the iris tissue or the pigment goes into the microfiltration track, which is around 200 micron. We did about 250 eyes with 70% success rate now. The first few years, we are doing for the last 4 years. First year we had a lot of failures because the iris tissue used to go inside the track. Then we started doing the iridectomy at some other place. It did not work, and now we started doing the iridectomy at the same level of the track. And for me, a primary angle glaucoma, with field changes. This is the first treatment of choice and not the drugs. I thank Professor Dr. Victor and Bhaskar Palmer to invite me for this wonderful meeting and show my video presentation on a difficult surgery made very easy for all of us. Thank you so much.